Hello, and welcome back to Sepsis Voices with Dr. Ron, the podcast where we speak to survivors of sepsis, those bereaved by sepsis, clinicians and change makers from around the world to better understand the impact of sepsis and what we can do about it. I'm Dr. Ron Daniels, and I'm the founder and chief medical officer of the UK Sepsis Trust. And over the last 15 years, we've been working to bring sepsis to the forefront of the public consciousness and political agenda in the UK. But of course, tackling sepsis isn't just a job for one country or one health system. It's a global issue, with 11 million people losing their lives to sepsis every year. And we all have something to learn from each other. That's why I'm thrilled to be joined today by someone leading vital work on the other side of the world. Now, Dr. Julie Dockerty is an emergency medicine physician and the principal medical advisor in the Patient Safety and Clinical Quality Directorate at the Department of Health in Western Australia. And she's working to build a unified system-wide approach to sepsis across Western Australia, the largest non-national state on the planet. And that sounds a bit bland. Western Australia has a population of just a few million, but it's the size of Western Europe, so brings unique challenges. It's a task, therefore, that involves navigating vast distances, rural and remote communities, and deep cultural considerations. And I had just a flavour of that when I visited Western Australia a few weeks ago, and Julie was kind enough to welcome me into her house for the 4 days I was there. So, Julie, from a personal as well as professional level, it's fantastic to have you with us today. Welcome.
Thanks very much, Ron. It's a pleasure to be here.
So can we just start with your personal connection to this work? What was it that drew you to sepsis as a priority? Obviously, as an EM physician, you will see myriad conditions every day. So why this particular area of care and why now?
So it's interesting to reflect, isn't it, as clinicians, what holds our attention in the multitude of illnesses that present to an acute care area, such as an ED, and why we're drawn to specific areas. From my perspective, sepsis has always been one of those sneaky illnesses where when it's advanced, it's fairly obvious and you'd hope that most clinicians would recognise it. But in the early stages of sepsis, it's much more difficult to identify and the consequences for the patient being profound if missed. So I recall a case that I saw as a middle grade registrar. I just recently returned to clinical practice from maternity leave, so I hadn't been practicing for over 6 months and felt rusty. It was a 6-month-old baby that had a fever for about 4 or 5 days. The baby was well looking, sitting up alert on mum's knee with no obvious focus of infection. However, this was now the third presentation, and this was an experienced mum. It was child number 5. And I remember being given a hard time by the nursing staff. I was a locum for wanting to do some bloods. You know, there was the eye roll. But I pushed on, I did them anyway, and the CRP returned at over 300. So Julie administered high-dose antibiotics, admitted the baby, and the diagnosis was pneumococcal meningitis. And thankfully, the baby had a good outcome. But I reflected about how easy it would have been to have dismissed this as relatively benign viral illness. So this really gave me an interest in recognition systems and evidence-based data to help clinicians in this area. Regarding greater involvement in sepsis systems, in 2021 in Western Australia, there was a case of a 7-year-old girl that died of sepsis. She presented to our tertiary emergency department, our tertiary children's emergency department. But unfortunately, the severity of her illness wasn't recognised at triage, and she waited just under 2 hours before being brought into the emergency department. Her acuity or severity of her illness was recognised at that point in time, but unfortunately too late for interventions to be successful, and she died less than an hour later. Generated a lot of media and investigations into the failure of the system with a multitude of recommendations to prevent a similar occurrence in the future. The organisation that I was working for at the time had implemented all of the recommendations, but there were still ongoing cases of missed sepsis within our emergency departments. So I was therefore approached to review why we were still missing cases of sepsis in our EDs. So I duly did so, wrote a report, and the results were not unexpected. I performed a gap analysis, made some simple recommendations for best practice, which included implementing a triage screening system for sepsis, a standardized sepsis pathway for management, antibiotic guidelines attached to the pathway, regular audit of outcomes, and education of staff. Having presented the findings, I thought I was done and dusted, but I was then asked to implement all of these recommended changes across 3 of our emergency departments, including 2 interstate. So I went on the hunt to find the best evidence-based sepsis systems. And I started with our tertiary quaternary hospitals within state. I looked at sepsis pathways in other states and territories. And then I expanded my scope to look at what was being done internationally with sepsis systems and pathways. And I have to say, Ron, it was very enlightening. I noticed that most of the national sepsis pathways at that time looked very similar, complex, 4 to 6 page documents incorporating fine detail for recognition tools as well as recommended pathways. Being a practical person, my question to myself was, well, when do you activate these pathways? And then I was told, well, you access the documents when you suspect sepsis. You know, they're tucked away in sort of cupboard or a shelf. And I'm thinking, well, why do you have a complex tool to help you assess for sepsis if you already suspect sepsis in the first place? The issue is that when the clinician has not thought of sepsis, and in these cases, the pathway isn't activated. So for me, there was a missing step. And that was a screening step which needed to happen at triage to filter out at presentation the smaller cohort of patients that are at risk of sepsis from everyone presenting to an emergency department. That screening step for me was answered by News 2. I'd first come across it in an up-to-date article on sepsis and sepsis tools, and in the Surviving Sepsis Campaign Guideline recommendations. Having found it, I did a deep dive on the Royal College of Physicians website about its development and its evidence base. As I also have a passion for acute deterioration systems, it very much resonated with me, and I now felt I had the answer to the triage screening problem. We therefore implemented a new triage protocol across the 3 emergency departments. All patients were to have a full set of observations at triage, which is not mandated in Australia. And a News 2 score was then generated. We linked it with a simple table of risk factors and symptoms of infection. And if you had a News 2 score of 5 or above with any risk factors or symptoms, you were made a triage category 2, which is to be seen in 10 minutes and placed on the sepsis 6. So I know you were one of the founders of this tool, so thank you very much. I love the simplicity. It's made by clinicians for clinicians. The perfection for me was step 1, which is senior doctor attends. And you're making a decision at this patient that has altered physiology. Do you think this is due to sepsis or another cause? Are they on the pathway or are they off it at that senior level? And if it's sepsis, you proceed through the pathway. We added a laminated 2-side antibiotic reference guide, which documented all potential sources of infection, so used as a cognitive trigger or reminder to look for different sources. And it had antibiotic recommendations for local sensitivities. And we also made sure that those antibiotics were available within the ED. The Sepsis 6, as you know, doubles as an audit tool, and we provided education for all our staff before rollout on both News 2 and the Sepsis 6. The project was successfully rolled out, and our data demonstrated that of the 200 patients with a News 2 score of 5 or above, out of 4,000 presentations in an 11-week period, 70% of those had an infection, sepsis, or septic shock. So we were very pleased with the audit results on that. Since then, I've taken a position with the Department of Health in Western Australia. I've been working there for the past 12 months, and I'm currently spearheading a project to standardise an early warning system across the state, with the preferred tool being News 2. And we can then link this to standardised sepsis pathways.
Fantastic, Julie. Thanks so much. I mean, it's not funny, but it is It's interesting, isn't it, how both of our journeys with this started with a very clear recall about an individual case. And, I remember my case, it was not a child, but an adult. Jem Abbott's was 37 when he died in 2004. And I remember clearly thinking this did not need to happen. He should not have died. He died leaving two young kids, Tom and Emily, his widow, Karen. They've all now moved on with their lives and are having happy, successful lives. But they shouldn't have lost Jem at that age. And that stayed with me, for the last 21 years and no doubt for the rest of my career. Just for those of you who want to dig deeper into the young girl who sadly died, her name's Ashwarya, and I think her legacy is Ashwarya's care call, very similar to Martha's rule. Is that's right, isn't it, Julie?
That's correct. Yeah, it was Ashwarya.
Yeah. So, like you, we began with a simple goal. And, people might not realise that the Sepsis 6 started in a little district general hospital called Good Hope Hospital in the West Midlands. And it was myself and my house officer and my senior house officer. I was just a registrar at the time. No, I wasn't. I was a newly appointed consultant. And one of our critical care outreach nurses. And we just sat down and said, we need to do something here. We've got the Surviving Sepsis Campaign guidelines, but there are 58 of them and no one's going to remember them. And so we need to condense them into something that a busy junior doctor or nurse can deliver. And that's how the Sepsis 6 was born. And from that sort of seed, it sort of grew organically, slowly, but strategically to a national movement for change where we're improving the early recognition and treatment of sepsis. And I think, we have saved many lives in that way, but we've learned a lot of lessons the hard way along the way. So it's fascinating how others around the world approach the same challenge, especially when the geography looks so different, like in Western Australia. So what do you know about the incidence of sepsis in Australia, and how does the scale of the state impact your efforts?
Western Australia is indeed enormous, Ron. It's over 2.5 million kilometres squared. It's over 10 times the area of the United Kingdom. Perth, which is the capital city, is almost 2,000 miles from Kununurra, which is a town in the north of the state. And this is about the same distance as Birmingham to Moscow, since you're based in Birmingham. And the nearest pharmacy to our remote town, which is Kiwikura, is in an adjacent state in Alice Springs, which is 500 miles away. So the stated figures for sepsis incidence in Australia is about 55,000 Australians annually, with an estimated 8,700 lives lost to sepsis. However, as you probably know, this is likely to be a significant underestimate of incidence due to data limitations. The population in WA has just topped 3 million. 80% of those live in Perth, 10% in the surrounds of Perth, with the remainder living in the rest of the state. So the geography does indeed impact on consistent care, as access to a tertiary teaching hospital versus a remote nursing post is going to impact on outcomes in time-critical illnesses such as sepsis. There are areas where clinicians don't routinely collect blood cultures, even in a known sepsis case, because it's going to take more than 10 days for them to get a result, which is way too slow to inform ongoing management. So it does indeed pose significant challenges.
Yeah, absolutely. And my very limited experience of this was I took a short flight from your house down to Albany, didn't I? Which is a remote location in the southwest sort of corner. And it was an hour and a half flight, pretty much like flying to Paris from here. And we had covered just a tiny, tiny bit of the country. But what really struck me in Albany is there was this really small hospital in this small but historically important town. But it had 24/7 access to CT scanning, which is something that some of our tertiary hospitals can't even guarantee to offer. So the service provision is really tailored to the geography from my limited experience. But even in a tiny country like the UK, or rather a tiny collection of countries like the UK, getting consistency across NHS trusts, even in the same city, is a challenge. There's a lot of intellectual property invested. There's a lot of ego sometimes, and people like to try to reinvent the wheel. So, it must be incredibly difficult to try to unite clinicians and services who are separated by hundreds of thousands of kilometres. It's a completely different ballgame. But it's also a reminder that good solutions don't always sort of scale in a straight line. So inevitably, you're going to have tension between a desire for standardization statewide and this sort of intellectual property, innovation locally, ego locally, that brings about these different ways of doing things. So how do you plan to navigate that as someone who's charged with this job?
Great question. So I think reflecting on my current project, which is to standardize the early warning system, is that, I come from a position that people's physiology isn't fundamentally different regardless of where they live. Even in the most remote areas, a basic assessment would be to perform a set of vital signs or observations. So that's your standardization. You should agree on a standardized chart. And then local adaptation can come catering to the level of what the response would be to the acuity of illness. So, for instance, in a major urban setting, the response might be a 4-person medical emergency response team with intensive care experience and so on and so forth. In the remote setting, the response might be a single nurse practitioner or a GP. However, we do have increasing availability and use of telehealth services and virtual emergency departments, which is helping to bring a higher level of expertise to the bedside in more remote areas of the state. And I think to address your question of personalities, is that a lot of the leadership structure is very central and actually only down to sort of 4 or 5 different what we call health service providers.
Thank you. And just to follow on from that, it really struck me when I was looking into healthcare in Western Australia, the fascinating cultural dynamic, and just my take, but it sometimes felt to me like there's a sense that Western Australia can feel like a poor relation of its cousins in the East when it comes to investment and innovation. And is this perception, my perception, does it have any truth in it? And how does that affect how willing people are to embrace new initiatives and new innovation in the state?
So I do believe you're referring to WA's pseudonym as Wait a While. So certainly I think when we look at basic scientific research funding, WA can be the poor cousin to the East in terms of grant funding and political considerations. However, the state also has some advantages, being large enough to give economy of scale, but without the size and population complexity that starts to make healthcare coordination efforts more difficult. Also, with this intermediate size, appears to come a spirit of cooperation rather than competition. Additionally, WA is a very resource-rich state. We have oil, gas, gold, uranium, diamonds. I have to tell my husband, not seen a lot of those yet, though. And the resources sector here does significantly contribute to state finances, leading to funding initiatives that are not available over East. Finally, we have some solid health data collection architecture and expertise in the state, which has produced some world-class data sets, such as the Bosselton and RAIN cohorts. So overall, I think with the economy of scale, willingness to collaborate, solid data set systems, along with a dash of pioneering spirit, it makes WA a great testing ground for rolling out population-wide health initiatives. And of course, it goes without saying that we always want to beat the eastern states in everything we do.
Yeah, absolutely, and that's a great answer. And we see some of that spirit in the devolved countries in the UK. There's a desire to unite and demonstrate the ability to do something much better than England's able to do. And obviously that's healthy and it's wonderful and it's in the patient interest. And Andy, if you are listening, do bear in mind the comment about the diamonds. I remember very clearly the miners, the internal flight I took, sort of 60% of the plane were wearing high-vis jackets and were clearly engaged in some sort of mining activity. It's a huge industry there, isn't it? But a big lesson we learned early on in the UK was that you really cannot impose change from the top and expect it to stick. So, of course, we have the NICE guideline on sepsis. Of course, we have the NHS England National Action Plan, which are both brilliant. Of course, we have leadership from our Royal Colleges, but we need so much more than that. They're not tangible to the the shop floor worker, the grassroots health professional who's busy in your emergency department. So the most effective tools we created, such as the Sepsis 6 and such as Red Flag Sepsis, were co-designed with the people actually delivering care. And we believe that's why we got traction with those. But even then, we've had to work hard. And in fact, we're still having to work hard to earn trust. And one sort of example of that is that initially we felt we had to be quite didactic, almost evangelical. You must do this. Whereas now we're much more nuanced, and we now embrace clinical judgment and the need for earlier senior decision making. So what's helping you? What tools have you got at your disposal to bring clinicians and communities with you?
I've had a very interesting time over the last 6 months engaging with health leaders with the proposal to standardise an early warning system and then link it with sepsis pathways. The reactions I've encountered across our health service providers have varied and encompass the whole spectrum encountered in change management. I've had incredibly enthusiastic receptions with instant recognition of the benefits of a standardised system and a willingness to initiate change. For me, this was one of my very early interactions, and I thought, this is easy. How hard can it be? But, from then I've encountered more guarded or mixed approached, right the way through to countering strong opposition. So I've worked to understand not only the concerns, but more importantly, the drivers behind them. I think it's crucial to address genuine safety concerns, but to have insight into when there's more at play, such as, I think what you've mentioned, vested intellectual interests. Ultimately, you need a great tool, willingness to engage in clinicians. I think knowing the data and doing the work yourself very much resonates when you have that interaction rather than being separate from the workforce and still practicing clinically, I think is really important. I think it's important to be respectful and listen to concerns, but being prepared to push on in the face of opposition, especially when you feel it's not backed by evidence or sound reasoning. In this particular project, for instance, there may be a hospital that already has mature systems for recognising and responding to deterioration, and there might not be significant gains for that particular hospital to adopt a new system. But standardization brings benefits across the whole system and improves the safety for the patient across the continuum of their care, from the community through to ambulance transfer and the ED interface. And currently we have different systems in use across this interface with no common language to discuss patient acuity. So working at the Department of Health, I'm tasked with having to adopt a systems perspective of whole of state approach as opposed to a single site approach. And I think that changes your priorities and therefore perspective. So this is for the whole population that I'm coming from, but having to understand when you interact with clinicians at specific sites, what their drivers are and understand and address their concerns.
Can we dig a little bit more into the rural and remote side? Now, the context of this is in the UK, we know that there are populations who do particularly badly with respect to sepsis. They're at much greater risk of death from sepsis, and that includes people who live in more socioeconomically deprived areas. It includes people from households of non-Anglo-Saxon ancestry. It includes people with learning disabilities and neurodiversity. And we're working hard to fix that, but it is really challenging. Now, I observe Western Australia is home to many Aboriginal communities and people living far from urban centres. So how do you strive to deliver culturally safe sepsis care? I'm not pretending we've got it right in the UK. We absolutely haven't. But how are we going to work to deliver safety for all?
We're striving again towards the similar goals as yourself, Ron, and we certainly haven't achieved it. And we've been trying to close this gap in terms of outcomes for our First Nations Aboriginal communities and struggling to do so over decades. Certainly our Aboriginal population can be overrepresented in hospital admissions. To give you an example, in Kalgoorlie, which is 7 hours from Perth, it's a mining town, the Aboriginal population is about 12%, but it counts for 49% of hospital presentations. As a broad summary with regard to sepsis, research suggests that presentations are modestly higher in Aboriginal people. But interestingly, the outcomes in those with established sepsis appear to be similar to the non-Aboriginal population. The higher incidence might be related to more frequent comorbidities. We know they have more diabetes, renal, lung diseases. Whether there's more frequent progression from local infection to sepsis, however, is unknown. Potentially increased remoteness, greater socioeconomic disadvantage, reduced health literacy, barriers to accessing culturally tailored and appropriate care could contribute, but definitely more research is needed relating to sepsis specifically to address these possibilities. It's interesting to consider that until recently, the Aboriginal population has been living an outdoor migratory lifestyle in one of the harshest environments in the world for tens of thousands of years. And this is in sharp contrast to what I call the relatively soft and protected environments to which Europeans have been exposed in recent generations. Therefore, there could be lessons to be learned genomically and biologically in terms of sepsis resistance and survival from our Indigenous populations.
Yeah, those are fascinating points. Is the biology different? Are the genomics different? And we simply don't know, do we? We know that there are people of all ethnic ancestries who have certain genetic mutations that make them more likely to develop sepsis as a consequence of infection with certain types of bugs. But, are there these ancestry-related differences in how diseases progress? So I observed a lot of very appropriate and necessary focus in recent years on improving healthcare outcomes for First Nations people, as well as real tangible drives to improve the respect and recognition of First Nations people. It wasn't just you, but everyone I heard open a meeting in my limited 4 days there prefaced the meeting with acknowledgement of the rightful owners of the land. But another thing I observed, and it's just a question and it's only my observation and thought process, is with all of this very needful focus on Aboriginal health and respect for the Aboriginal people, is there a tiny, tiny risk that people of non-Caucasian ancestry with different ethnic backgrounds might fall through the cracks?
This is certainly something that we have to consider on. However, I think healthcare initiatives that focus on improved outcomes for First Nations people will often benefit the culturally and linguistically diverse populations. Australia has vast cultural diversity, and I think a failure to understand cultural beliefs and priorities can lead to poor uptake of services and consequently poor outcomes. Cultural diversity also comes hand in hand with linguistic diversity. Over a quarter of Australians don't speak English at home. Consequently, both community education, prevention initiatives, and treatments have to cater to this issue. Culturally and linguistically diverse peoples often live more remotely and may have greater socioeconomic disadvantage, which can compound poor outcomes. We do need to be able to address and overcome these issues both individually and in combination to improve equality of care across all population groups.
And it's really difficult, isn't it? And as I said earlier, we've certainly not got this right in the UK, and we're well aware that groups have poorer outcomes. And we have to try to understand how to get over that. And that has to involve working with those communities and understanding how race and class and language and geography and socioeconomic status intersect and create these barriers to care. And so these global conversations have to matter. We have to learn from each other. We need to move beyond thinking in silos. So colleagues might be listening in from other countries, or change makers who aren't clinicians might be listening in from other countries. So what do you think the world can take from what's happening in Western Australia? Because I think there are some important lessons for you to share.
I think putting aside our geographical size, WA populations and health systems are of a size and maturity, I think, well suited to trialling and maintaining broad-reaching health service initiatives. I've learned, as many before me, that you can't please all of the people all of the time. But if you find a solution supported by good data, refined by outside experience, that's acceptable to a reasonable majority, you have a platform on which to proceed. Hopefully in time, with concern of exclusion, as well as the inducement of resources attached to compliance, we will actually achieve statewide cohesion.
Yeah. And I think you're going to get there from what I observed, again, in my very limited experience of 4 days in the state. But the enthusiasm and the passion is absolutely there. It's just channeling it, isn't it, now, to make sure that the early adopters begin to bring on board the later adopters and the skeptics. And it will happen, I have no doubt about it. So is there any advice you'd offer for someone listening from another country who thinks, well, we should do this. I want to do this. I want to lead this change. I'm going to speak to my Department of Health and see what we can do. What advice would you offer?
I think firstly, you've got to start with a good evidence-based tool that's got face validity for use in your setting. I think that's crucial. If you start off with something poor, it's absolutely not going to get off the ground. Secondly, I think it's really useful, and it's certainly helped me to have support at more senior level or some sort of executive sponsor. I've been very privileged to have had two exceptional mentors during my career, Professor Ian Rogers and Dr. Stephen Bolson. You might remember Dr. Stephen Bolson. He's well known in the UK as the whistleblower regarding the high rates of a paediatric death post-cardiac surgery at the Bristol Royal Infirmary. And he called this out and sacrificed his career, his family living in the UK, to call this out to the public. And it resulted in clinical governance reform across the whole country. Both of these clinicians have significantly impressed me with their intellect and character and have been very supportive of my work. Now, having moved to the Department of Health, I'm also privileged to have great executive support with Dr. Audrey Coe, patient safety and clinical quality. So I think it's great if you've got someone in a position of authority that's your backer. Thirdly, I think it requires a lot of energy and drive to make the change. I don't think this is lacking amongst our peers who are driven to improve systems. But it's important to acknowledge that along the way that you're going to cause upset, despite the most respectful and diplomatic of approaches. And I think my experience is that there'll always be people who oppose change for a multitude of reasons, and they're not necessarily based on logic, evidence, or sound reasoning. And lastly, find allies. Use them to help you achieve your outcomes.
I have learned many of those lessons the hard way. I met Audrey when I was with you, and she's a hugely impressive person, an absolute force of nature. I really regret, I'm gutted I didn't get to meet Stephen Bolson, but it wasn't possible, was it? And what he had and the reason for his sacrifice can be described in a single word. It's integrity. And from my perspective, I think you have to have integrity to bring about change. You have to have true belief in doing the right thing, but also humility, the understanding that you don't know it all, and you have to listen and you might be wrong sometimes. And with all of that, driving something forward, understanding that you're fallible, understanding that your purpose and your cause is the right thing to do, but sometimes you get it wrong, means you have to be extremely thick-skinned, don't you? You can't be cowed by criticism, because you will get criticism, and the critics will be the minority, but they'll be the minority with the biggest voice, particularly in the days of social media. I've had to develop a very thick skin, and you have and will continue to do so, and anyone leading change needs to understand that. I think the only thing I'd add is flexibility. The Sepsis 6 hasn't always started with Inform the Senior Clinician. I mentioned earlier that we started being quite didactic and evangelical, and now we're very much more nuanced, and that's in response to criticism. And we have to listen, don't we? Listening is the most important thing we can do.
Interesting that you talked about there was a number of iterations as the Sepsis 6, because I'd heard of this and learned this for my fellowship training. And when I was looking at it, like, please, will the real Sepsis 6 stand up? It's like the song.
Maybe we should do that. Maybe that's a marketing tool. I am joking. Julie, look, thank you so very much for joining me. Thank you once again for inviting me into your home a few weeks ago. And thank you for sharing your work and your wisdom for our audience with such clarity. Your approach shows that you can do it, that system-wide change is possible. It can be done. It just needs dogged determination, expertise in listening, and expertise in change management. And it can be done even in the most challenging environments like yours. To everyone listening, if you took something from this episode, please share it with a colleague Rate and review us and subscribe if you can to Sepsis Voices, wherever you get your podcasts. You can learn more about sepsis and our work in the UK at sepsistrust.org. Thank you again for listening. And remember, sepsis is a medical emergency, but with global collaboration, shared learning, and bold leadership like Julie's, we can save lives.